Good afternoon. We're going to go ahead and get started with our next session. So I'm Dr. Marcus Noel. I'm a GI medical oncologist here at Lombardi and honored to chair the next session. So we've put together a great panel, which includes Dr. McCleary, Dr. Dash, and Dr. Griffith will come back up for our discussion. So thanks everyone for joining virtually and online. It's really exciting for me, being my first in-person meeting since really January of 20. So it's been a while, but it's so great to see everyone's faces and interact during the breaks. So I'll introduce our first speaker, Dr. McCleary. She earned her Bachelor's of Science degree in nursing from the University of Pennsylvania, and then went on to earn her Master's in Public Health and medical degree from Johns Hopkins University, Bloomberg School of Public Health and School of Medicine. She completed her residency in internal medicine at Johns Hopkins in 2006 and then fellowship in Hem/Onc and Dana-Farber in 2009. Dr. McCleary joined the staff of Dana-Farber and Institute in Brigham and Women's Hospital in 2009, where she was a medical oncologist and a clinical investigator. Her focus is in GI cancer. She also is focused on improving health and treatment outcomes for older patients with cancer. Interestingly, she actually has quite a unique clinic where she's able to see patients as young as 12 years old up into their 90s, so a wide range of age there. And she's going to discuss clinical trials in oncology and the push for equity. This is a really important topic as obviously we're here mainly focused on research at the symposium, but understanding that oftentimes our research subjects don't reflect the data of the general population. And so can't wait to hear what she has to share with us this afternoon.
Good afternoon, everyone. Just extending my gratitude to John, Dr. Marshall, and Dr. Noel for this invitation. And I'm so honored to follow Dr. Griffith's, his amazing talk, and looking forward to Dr. Dash's talk as well. So with that, presuming this is next. Okay, so Dr. Noel already introduced me, so I'll move forward. I have no disclosures. So I wanted to start, primarily this is a talk about the need for diversity in clinical trials and really the push for equity there, because that's where we learn and develop our treatment decisions and create our algorithms. But I wanted to really share the experience with permission of my patient, Mary. So Mary began having symptoms of cancer unbeknownst to her in January of 2020, just before what we were alerted to as the onset of the pandemic. She began with nausea, pain, some weight loss. And because she'd had weight loss surgery in the 1970s, her primary care provider presumed it was related to that, prescribed some medications, really thinking that this would help. But it did not help, and her weight loss continued to a point where she was unable to eat. In fact, for her mother's 90th birthday, which was a pivotal moment for her, she was unable to eat. And at that point, she really said, I need to get some help. So while shopping in August 2020, sorry, not 2022, she nearly collapsed and she was admitted to an emergency department locally, was hospitalized for a week. Ultimately, she had a gastroenterology evaluation. They said, you have some blockages. This is probably due to your weight loss surgery back in the 1970s, just emerging 30 plus years later. And then she was discharged to GI follow-up, which wasn't going to happen for another few months. So it wasn't until January of 2021, ultimately, with symptoms beginning a year earlier, that she was formally diagnosed with advanced colorectal cancer. So at that point, Mary was, admittedly a little bit weary of her care team and felt that at this point they were moving too quickly after waiting a year to get a formal diagnosis, and she didn't feel that she was in control of her treatment options. So she met with me and she asked me very clearly, and she brought support with her, and she was very clear on what she wanted to know and what she wanted to hear. And she said, what would you tell your sister? What would you have your family member do? And she ultimately decided to join a clinical trial and I was surprised by this given her course thus far. But she said, this is because of the trust that I had in my care team. And she said she had a good sense of what to expect. She knew that the research team would be there in addition to her regular oncology care team, and that there would be additional supports provided for her throughout her care. And so she was able to join a really promising clinical trial and remain on that trial for close to a year with some good results and stability in her symptoms before needing to move on in her treatment. So I wanted to pose two questions for our talk today, which is how do we make these decisions about the optimal treatment for cancer diagnosis and its treatment itself, and then why is there a disparity in how we apply these decisions? So much of this has been covered, I'm sure, in the earlier talks and just recently with Dr. Griffiths, but just to make you aware of kind of the standard is that we should be doing colonoscopy screening, age 45, recently recommended, but at least by age 50. And that there's a formal way that we do staging for cancers. We assess for the risk of local recurrence. We will look at lymph nodes, particularly for rectal cancer with MRI-EUS. We'll do whole body staging as well. We'll make decisions in the case of rectal cancer, perioperative or postoperative treatment, and that there are trials that will guide us and will modify the treatments that we recommend. So in the case of rectal cancer, just pointing out the PROSPECT trial, but there are many trials that come along the way that make us adjust our treatment recommendations. And so when we think about colorectal cancer here, rectal cancer specifically, there have been many improvements along the way that have led to substantial reductions in distant recurrence by about 30% and local recurrence a little bit more modestly. But because of kind of putting forth questions and asking these questions of the population, that is diagnosed. Yet the outcomes differ for a subset of adults. And here I just want to frame the way I think about health disparities and health inequities. Health disparities are a population where there's a significant disparity or difference in the overall rate of disease incidence, prevalence, morbidity, mortality, et cetera, compared to the health status of the general population. Here I'm speaking about inequities, which is we look at those differences or disparities in health, and then it becomes systematic, and it could be avoidable, and it's certainly unjust. So we know that when we look at the numbers, just the sheer incidence and death rates of cancer by gender and also by race, we can see that I'm highlighting here Black patients, just thinking about my patient Mary, have a disproportionately high rate of cancer incidence and death. We could see the same for Latinx or Hispanic patients as well. And thinking about colorectal cancer in particular, there are higher rates of incidence and death regardless of the stage at diagnosis. So many would say if we could screen earlier, maybe we can shift that. In the case of our colleagues in Delaware, I'll show you in a moment that they were able to do just that. So there are multifactorial disparities in colorectal cancer care, starting with the incidence, third most common cancer in African American men and women, 20% higher incidence in African Americans despite decreasing incidence overall, late referrals due to challenges with payment structure, but also lack of referrals for screening. Treatment, timely referral to oncology, as the case of Mary, was delayed. Mortality and survivorship, there are fewer folks living beyond 5 years since their diagnosis. And then risk reduction. We have made a lot of progress in terms of risk reduction, in terms of genetic screening for hereditary cancers and genomic testing for both hereditary and sporadic cancers, but yet we're not seeing the translation of these benefits in certain groups. So I'll share just an intervention that was pretty impactful to me. This was the Delaware experience, where they really observed that there were disparate rates of colorectal cancer screening for Caucasian patients compared to African American patients. And they really sought to do something about that. And so what they did was mandate that all screening is paid for and that we're going to track you as providers. So not putting the onus on patients, but really on the providers in the healthcare system to monitor them. And so starting in 2001, they noted that patients diagnosed with local disease was very small, about 15%. Regional disease occupied the majority of patients diagnosed. And by 2009, they were able to see a shift in stage of diagnosis in that they were able to diagnose patients a bit earlier with local disease. And I think someone mentioned earlier, when we help one group, we're going to help everyone. That was the Delaware experience as well. So they were able to notice that by shifting this stage of diagnosis to a bit earlier and local, not only were Black patients less likely to die from their cancer, but also this improved outcomes for Caucasian patients as well. And so it has been said that the majority of colorectal cancer disparity could be addressed just by ensuring that we get proper screening, probably 60%. That seems reasonable. But it still leaves us with about 40% that requires attention to every single phase of cancer care. So not just screening, but also prevention, diagnosis, treatment, end of life, and survivorship care as well. And so here for the rest of the talk, I really want to focus on treatment disparities, particularly in regards to clinical trials and all of our preclinical trials as well. The reason being is that this is how we make our decisions and set our treatment standards. And it is increasingly based on cancer's molecular signature, the genomic underpinnings of the cancer that we're treating. And so genomic testing is available, and we know it is an evidence-based intervention, but unfortunately underutilized in many settings and for many reasons. So I want to spend some time talking about that. So there are many processes of care along the cancer care continuum. And we're going to focus here on treatment, and there are many pillars, and we're often speaking about immunotherapy as kind of being our most recent and fascinating pillar, but surgery, radiotherapy, cytotoxic therapy, molecularly targeted therapies, all of which have emerged from this long process of clinical trials. And we are familiar with this as being kind of a linear improvement from phase 0 to 1 to 2 to 3, and then hopefully post-marketing trials as phase 4 studies. But what we often don't remember and what our patients sometimes don't realize is that these studies take years of development, years and many, many millions in investment. And we have been investing just to get from several compounds, in this case, 10,000 compounds, to one active or approved drug. And so if we miss the mark in terms of patients who are enrolled and engaged in these studies earlier on, by the time we get to the approved study, we're kind of upside down on that investment, and we've not really made a significant improvement. In fact, when we looked at the numbers in terms of patients, and this was done by a large group of patients who said, 11% of the sites fail to enroll even a single patient in an open trial. 37% don't meet their enrollment goals despite the investment. 40% of those adults surveyed don't even understand what a clinical trial is, what's the purpose, why am I participating? But 32%, which is hopeful, 32% said, if I understood what it was about, I would do it, right? So tell me, it's not that I'm not willing, but tell me why this is important. So why do we still have this disparity if our patients at least are indicating that they may be interested and willing to participate and learn and benefit from these studies? So I'll point to a study done by our current Surgeon General, Vivek Murthy, but this was done in 2004, and I'm going to emphasize 2004. Was when the study was done. And so what he and his co-authors did was look at the National Institute of Health Revitalization Act in 1993. And there, the act produced a lot of increased funding, increased budget for the NIH to really support enrollment of women, minority populations, and question mark on older adults, but there was a nod to older adults as well. And so it led to a doubling of the NIH budget from 1993 to 2002, and this increase in the number of clinical trials that were able to get funded. But there were conflicting reports on representation of racial and gender groups based on this funding. And so Dr. Murthy and colleagues really sought to understand, does enrollment in clinical trials change from 2000 to 2002 based on cancer incidence? And then has enrollment really changed over time? Just after this funding was initiated to this point in time of 2002. And so they did this by looking at all NCI-sponsored therapeutic trials. So these were drug studies. They pulled all of the population data from SEER, and they also looked at the enrollment fraction, which is the number of trial enrollees versus those diagnosed per subgroup in the US population. They looked at over 75,000 NCI-sponsored trials, which represented 75,000 patients enrolled in these trials, representing 1.7% of the US cancer population. And they noted that the majority were Caucasian patients, so overrepresentation there. 9.2% were Black, 1.9 Asian Pacific Islander, and very few American Indians or Alaskan Natives, and only 3% Latinx. And so to answer their questions, does enrollment match cancer incidence? It did not. So the enrollment fraction based on disease was below what we would have expected based on the incidence in the general population, and that Black patients were nearly 40% at lower odds of enrolling in a breast, colorectal, or lung cancer trial. Latinx patients were also less likely for all cancer types studied, and Asian and Pacific Islander patients less likely for colorectal and lung trials specifically. And unfortunately, not only did enrollment not change over time, but in some cases for Black patients, enrollment actually decreased. Went down from 11% to 8% in the time study. So there was proportionally less enrollment despite the influx of funding and the increased attention to this issue. And since then, there have been many such studies noting the disparity and really just studying the epidemiology of what's happening, but few really targeting how we develop interventions. So remember, Dr. Murthy's study was in 2004. Here, Dr. Guerrero with colleagues evaluated not only applied research or clinical trials, but also our fundamental or basic research and looked at what are the rates of enrollment or participation or submission of tumor samples to early studies of cell lines and oncologic models, biobanking studies, genomic studies, and then the clinical trials. And unfortunately, you can see here reflected that some of the racial and ethnic information was just not available. So about 50% for cell lines, and fortunately a smaller proportion not represented for genomics. But then the majority of patients who submitted samples or were participating in these studies in the basic research field were Caucasian. And then as you go around the loop and you look again for clinical trials, overwhelmingly 67% where we're missing some data. But when you pull out the data that we have, we still have a paucity of patients who are racially or ethnically diverse participating. So what are some of the ways that we should be thinking about or framing this challenge? Well, first, we need to think about appropriateness. So applying trial results to patients where they were not reflected in the study may not be appropriate and may be associated with harm. There's also a question of proportionality, so that the distribution of trial participants across race or age groups should mirror the distribution of those diagnosed with cancer in the general population. And then lastly, and this is where we stumble, we don't know what degree of representation is optimal. At which point or threshold would you say, we've got it, we have adequate numbers of patients, and that to me remains unclear. We've alluded to and we've touched on systematic barriers, including racism, including trust. And I appreciate Dr. Griffith mentioning the fact that we push that trust often on our patients and hold them responsible. But just to highlight, there's a reason for our patients, particularly Black patients, but also Latinx patients, to have some concerns about enrolling in clinical trials. And these are fantastic books to read if you have time, Medical Apartheid and Bad Blood, but also many of us are familiar already with the Tuskegee study, and it continued in Guatemala even after it stopped in the US, and then Henrietta Lacks and her cells, which have been in the press even more recently. So thinking about how we can actually intervene and do something, how can we repair trust that has been broken over years and decades, and how can we broaden access for patients who have been historically removed from having access by the policies in place and by the payment structures in place. So one of the ways that we're doing this in the Boston area and at Dana-Farber specifically is by broadening access to next generation sequencing. The rationale being this is where really we've developed a lot of our understanding of cancer, its biology, treatment options, and its impact. We've partnered with colleagues at Boston Medical Center. We've partnered with colleagues at Mass General Hospital as well to expand our offering of clinical trials, but really broaden access to the systems we have in place to truly leverage the results of genomic testing and match patients to precision clinical trials. We're expanding this out to our satellites as well, which represent patients who are more diverse than the patients seen at the main campus. And then we've lowered the cost of next generation sequencing. So for many of our patients, the cost of sequencing is free to them. It's something that we take on as an institution. We're also reducing barriers. We're exploring what the barriers are, really from the patient's perspective, their proxy's perspective, from the system level perspective. So we're targeting minority patient enrollment, as Dr. Schrag, who was a colleague at Dana-Farber until recently, did with Dr. Bosch in the PROTECT study. We also have a patient navigation a team in place to assist patients and guide them through their care, which is often complex. And then also provider training, because we know that it's not our patients who hold the responsibility for this, but providers as well. Advocacy is a huge part of what we do, and our advocacy team works very closely with the Massachusetts state government on payer coverage, but also on flexibility in when and how we can see our patients, and then addressing social determinants of health, and I'll share a study where we're doing exactly that. And then lastly, building trust. So clinical decision support tools kind of reduce the bias because it removes the onus from the provider to remember or recognize that there's a signal here that they should be paying attention to, and it helps us to increase access to trials. So many of you are familiar with clinicaltrials.gov, which is a very challenging tool, I think, for most patients to use, no matter what their educational level or their motivation to use it. We have MatchMiner, which is actually built for providers, but soon will be built for patients to use as well. What that does is once a patient has their genomic testing, automatically plugs that into a database that pulls up two things. One, their genomic results for researchers who may have trials that match to them, but for the treating provider also pulls up trials that match to their patient. And that has reduced the time lag to getting to important trials and helped our patients really engage carefully and thoughtfully in enrolling in trials. And I'll share how we're incorporating that with our patients. So knowledge is power. We do need to confront genetic testing disparities, and the promise of all of these early intervention tools, prevention tools, and I would add treatment, are likely to increase the healthcare disparities gap rather than close them if we do not pay particular attention to how those tools are rolled out and implemented. And so I did not look at Dr. Griffith's talk beforehand, but I'm so happy he mentioned implementation science, because that is exactly the approach we're using, saying that genomic testing is an evidence-based intervention. There should not be a disparity. There should not be a question as to whether we should be doing this. We should be doing this, and we need to figure out how to do it within our patient population. So in 2016 or thereabouts, I formed the patient-reported data program at Dana-Farber, which really leverages patient report of their experience of care, their outcomes, but also their risk, their needs, their social determinants of health. And we pull that information together and align it with all the other pieces of data that we have. So imaging data, clinical data, diagnostic data. And we leverage our clinical informatics applications to improve not only access, but can improve cancer care delivery amongst those patients who we know have been historically marginalized and in some cases silenced in terms of their health care. In our case, we're focusing on those with racial or ethnic minoritized populations, older adults older than age 70, and those with limited English proficiency. So I'll share with you 3 studies that are examples of what we're actively doing now. So one is SURGE, which is addresses barriers to genomic testing uptake for cancer clinical trial enrollment. So this is kind of divulging, this is what Dana-Farber looks like now in terms of our trial enrollment. It's not a pretty picture. So similar to Dr. Guerrero's representation, is actually skewed a bit further in that 90% of our patient population enrolled in cancer clinical trials, despite that being our primary focus, are Caucasian, and very few else. And this is not, despite what you've heard, is not representative of the Boston population. Boston population is a majority minority city, and yet our patients aren't reflected in our enrollment rates. So why is that? Well, maybe it's lack of awareness. That's a possibility. There's lack of cultural and linguistically appropriate education materials, and that remains the case, unfortunately, in many studies. Stringent and unrealistic eligibility criteria that often conflict. There is, on the patient side, fear of side effects. On the provider side, a challenge with really telling patients how to mitigate those things. There's mistrust of research ethics. There's also concrete needs, transportation needs, concerns about cost, concerns about food security, and there are also physician, and I would add research team assumptions about whether someone's appropriate for trial without actually checking the boxes on a list. So genomic testing disparities, I would argue, contributes at least in some part to the observed differences. This is actually a study conducted by one of my colleagues at MGH, Ryan Knipp, looking at patient enrollment from 2011 to 2014, nearly 3,000 patients enrolled in phase 1, 2, and 3 studies. And what they found, this is at Mass General Hospital, which has a slightly more diverse population than we do at the Farber, is that despite that, they have a lower odds of enrolling patients in phase 1 trials for their cancer diagnoses. And this is striking because we know that phase 1 trials for many patients offer the opportunity for additional care. So for Black patients, 54% less likely, Latinx patients, 75% less likely, and Asian patients were actually 38% more likely to enroll. So SURGE stands for Supporting Underrepresented Minorities in Genomics-Based Cancer Trial Enrollment. This is partially funded by Bristol Myers Squibb, as well as the Stansky Family Foundation. And so we're focused on patients with either racial, ethnic, minoritized group, or limited English proficiency, LEP, or coming from a low socioeconomic zip code and or older adults. These are reflecting all of those groups that Dr. Murthy and Dr. Guerrero highlighted are under-enrolled. We're looking at patients with advanced GI, lymphoma, or thoracic malignancy. And the objective is to increase not only readiness for clinical trials, awareness of clinical trials, but getting patients to say yes to the needed genomic testing that is so often delayed or neglected in their care. And what we expect the impact will be is that we'll increase next generation sequencing testing rates, which will then allow patients to become eligible for clinical trials and prepare them for that, should that be an opportunity for them, and then ultimately lead to an increase in precision clinical trial matching, or at least a signal that we can achieve this in historically underrepresented populations. And we're doing this through patient reports. So patients are self-identifying based on their race, they're giving us their demographic data, and then we're reaching out to them specifically with a concierge for clinical trial navigation, asking some baseline questions about readiness, willingness, awareness of the role of clinical trials in their care, providing education and an educational video for patients, reducing the cost of actually getting that testing done, and actually making it easier for them. It is a very complicated algorithm. I did not want you to have to read this, but the reason I show it is just to show all of the different pieces, the moving parts that had to be coordinated to make this effort actually come together. And what's still striking for me, and I know Dr. Lathan, who's also assisted in this work, is striking to him as well, is that we had to do this any at all. This should not be necessary. This should be a given. Any patient coming to the Dana-Farber should be able to plug themselves right into the tools and resources that are available. And yet we actually had to sit down with multiple pathology groups, multiple the tissue banking teams, and pull everyone together to say, hey, we have a gap, and how do we fix it? I'm very proud to say that my colleagues did come together, and they agreed to fix it in a way that actually works for our patients, and we have patient engagement to verify that. The second to last study is called Resource, which really focuses on unmet social determinants of health needs. I did not mean to show this equation. I couldn't pull the slide, but Dr. Griffith alluded to the fact that you can't really sum things up, but some studies would say at least some social determinants of health barriers account for about 40% of our health outcomes. And so in our study, we're acknowledging that these are barriers that impact all levels of cancer care, including screening delays, treatment interruptions in the form of ED visits and hospitalizations to acquire care, reduce access to testing, novel trials and therapies, reduce quality of life, and decrease survival. So Resource really targets those transportation, housing, food insecurities, allows patients to be screened for them, again through their report, matches them to the resource specialists to be able to provide and intervene earlier before crisis occurs. So patients are telling us what they need, and they're getting that support right away. So despite what you may have heard about the Longwood population, Dana-Farber campus, our patients actually still have need. Patients who are coming to that site, based on the study, have already told us that nearly half of patients have one or more needs. This is new information for us. 21% with food insecurity, not as many with housing insecurity, nearly 20% with financial barriers to medication adherence, particularly important for those on oral therapy. So we have, in addition to that work, we're partnering with the Cancer Care Equity Program led by Dr. Lathan, pioneering this community-focused patient navigation in our system, which is novel for Dana-Farber, not novel elsewhere, but we are doing this with the support of the institution. And then lastly, Resilience and Equity in Aging, Cancer, and Health focuses on the needs specifically of older adults, also an underrepresented and untapped group in terms of basic and applied research. And so this is a study that is launching, that's a wraparound service for patients who are seeking care. And so with that, I wanted to thank Team Bushy Strong, so a grateful patient who has really supported a lot of this work, and all of the funders, family foundations, the High Point Investigatorship, but really our patients, particularly Mary, who continue to lend their story and lend their voices to motivation for this work. Thank you.
We're going to hold questions until the end. Thank you so much, Dr. McCleary. That was an awesome talk and lots to unpack there. So I'd like to introduce Dr. Dash as our next speaker. Dr. Dash is an Assistant Director of Health Disparities Research and an Associate Professor of Oncology in the Office of Minority Health and Health Disparities Research at Georgetown Lombardi Comprehensive Cancer Center. He's also a member of the Cancer Prevention and Control Program as a secondary appointment in the Department of Biostatistics, Bioinformatics, and Biomathematics. Dr. Dash's expertise is in design, implementation, and analysis of epidemiologic studies, and his research primarily focuses on molecular epidemiology and cancer prevention and control in minorities and underserved populations. In his role as the Assistant Director of Health Disparities, he collaborates with Dr. Adams Campbell, who's Associate Director of Health Disparities Research, in directing community outreach and engagement efforts in Lombardi's catchment area, including conducting needs assessments in the community served by the Cancer Center. In this role, he supervises and collaborates with the community outreach staff at the OMH to successfully recruit participants, especially those from underserved areas for epidemiologic and intervention research in cancer prevention and control. His talk is going to be focused on colon cancer screening. So really excited to hear what he has to share with us. Dr. Dash.
Thank you, Dr. Noel. Good afternoon, everyone. As Dr. Griffith said, if it was tough to be the first speaker after lunch, imagine to be the last speaker before cocktail hour. So, but I'll try. What we have, thank you, Dr. Marshall, Dr. Noel, the outstanding Ruesch team for putting this together. And another post-pandemic milestone for you, the whole panel is in person, and not one of them is white. So, but we are all taking precautions. We're all masked. We're social distancing. We're almost 3 feet apart. But you know, we're all doing good. I have Lysol in my left pocket, ivermectin on my right. I'm ready to mingle. So let's get started. I'm going to talk about health equity in colorectal cancer screening. We have talked about treatment. Let's move on to, let's see, which one is it? Perfect. So I have no conflicts to disclose. We have seen the focus on health equity from NIH, CDC. I'm going to talk a little bit more. So Healthy People 2030, as a nation, that's our plan of where we are supposed to be in 10 years. 9 from now. One of the vision statements you can see there, but the reason why we focus on health equity is for Healthy People 2030, it's a foundational principle. It states that the health and well-being of all people and communities is essential, and eliminating health disparities is the only way we're going to get there. And the reason why colon cancer is so good is that that is one of the leading indicators of how we are going to achieve Healthy People 2030. We are trying to increase the number of people, or the proportion of Americans screened for colon cancer to 74.4, but I think all of our societies are a little bit more ambitious and getting to 80% target. So when we talk about disparities, we usually focus on gender, on race. However, if you look at this AACR report on health disparities, it's across multiple sectors. We look at ethnicity, we're looking at ancestry, we're looking at socioeconomic status, gender, sexual minority, where you were born, 65 plus population. So you have seen this before. What we are looking at over here is that there are gender disparities in both incidence and mortality between men and women. There are racial and ethnic disparities in both incidence and mortality. And there is geographic disparities. You look at that middle part, the Southeast and the Midwest, and that's where you see higher incidence and mortality. And on top of that, you have socioeconomic disparities. So 35% higher mortality in men living in the poorest counties of the United States. There are local disparities too. If I showed you the map for mortality from colorectal cancer disparities, you'd see DC is doing pretty well. We are doing really, really well. But if I break it down by wards in DC, you see those dark blue areas. That's southeast DC, east of the Anacostia River, with a predominantly African-American population. And you see in terms of both incidence and mortality, not doing so well. The problem is, it's probably the only cancer where we have had randomized controlled trial data from screening to show that it actually decreases mortality. We not only have one test, we have 5 or 6 astoundingly effective tests, and yet the number of people who get screened for colon cancer is less than the number of people who will get screened for breast cancer. And there are disparities too. So you don't have to go through all of this, but Massachusetts is up there, and you see the rates of colorectal cancer screening are pretty much close to where we want to be in 2030 in Massachusetts. DC is up there too somewhere. However, there are other issues over here. So you can see, even if you look at age, younger age groups are less likely to have colorectal cancer screening. We have talked about race, ethnicity differences. In sexual orientation, there is some sexual minorities have lower proportion of being up to date on colorectal cancer screening. People with low education, who are immigrants, whose income level is low, and who are uninsured or insured on Medicaid have much lower colorectal cancer screening than compared to the other groups. DC is doing pretty well. So what you see here is that the overall rate is around 74%. People in that 70 to 75 year age group, the elderly, they're actually much more than what we are trying to achieve by 2030. They're at 84%. However, that younger age group, 50 to 59 age group, it's low, but not that bad. By gender, there doesn't seem to be any statistical difference by gender in DC, and both gender seems to be high. By race, both African-American and white populations have almost similar screening rates in DC. The Hispanic population is slightly low, but not statistically significant. So it seems like there aren't many screening-related disparities in Washington, DC. However, what I'm going to do is focus on special populations. And the reason we call it special, I'm calling them special, is if you dice through those commonly seen categories, race, age, ethnicity, and other things, what we have realized is that they're not homogeneous. I mean, we know they're not homogeneous, but if you look at the data a little bit closer, there are differences. And one of the things we wanted to focus on are people with low socioeconomic status and the elderly. So that's the first example I'm going to talk about. So people living in affordable housing residents, the reason we got interested in them is as part of our community outreach and engagement efforts, the Lombardi Cancer Center has a community advisory council, which recommends what our priorities should be. One of the priorities they came forward with is that there are environmental justice and air pollution issues that seem to be really high priority, and they wanted us to do something about it. So we collaborated with public housing or affordable housing residents, and we did a couple studies on environmental justice that led to more collaborations and needs assessment. And what it turned out is that the residents of affordable housing units wanted more education about healthy diet and physical activity as prevention for cancer and how it affects their health. But also during this time, we started a collaboration where people from public housing were being referred to our breast cancer mammography program. So the next question was, what can we do about it? So with some foundation support and with the collaboration of the two people you see here from our staff, Jennifer Higgs and Jillian Anderson, respectively exercise physiologists and dietitians, we came up with senior housing improvement through education and healthy living in the district. We called it SHIELD. It was focused on colorectal cancer, and what we are trying to do is go to low-income senior housing locations, primarily target African-American participants. And what we did was we went to about 8 low-income senior housing locations, about 94 African-American participants. You see the mean age was 67, 45% were males. We were surprised at how many men came forward to take part in this study. So basically, it was a health education and increasing colorectal cancer screening. So we would go to these senior housing units and we would talk about the importance of having a healthy diet. Our exercise physiologist would go there, and these were seniors, and she would show them how you can safely increase your physical activity with resources you already have. We also gave them some exercise bands and other low-tech things so that they can keep it in their common area and use them. So that went well. Now, one of the things we wanted to take advantage of was that since we are going to talk about colorectal cancer prevention, why not try to see how many people were screened for colon cancer, and they weren't, we would navigate them to a colon cancer screening program by giving them fit kits, and if it was positive, we would navigate them to colonoscopy. So what did we find? How successful we were? Well, turns out we did not have included colon cancer screening. About 98% already were up to date on their colon cancer screening. Only 2% needed fit kits, and we were surprised. Well, some of the things we were thinking of, and we're writing this up now, is maybe since we're looking at senior housing, and you would have seen that a really high rate of 70 to 75-year-olds and 65 to 75-year-olds are screened in DC. The other thing is that if you live in government-sponsored housing units, there are people who help you navigate your health insurance, and you are insurance. And they have other systems in place which navigate people to medical care, including screening. The other reason could have been that people who chose to participate and come down and listen to us might be people who are really interested, and they might already be screened. So having those caveats, one of the questions was, does living in affordable housing, government-sponsored affordable housing, does it mean that you reduce colorectal cancer screening barriers? Well, in a large study, we didn't do that, but in a large study with a national sample, it turns out it's not as simple. So people living similar income level, people living in public housing were not more likely to have colorectal cancer screening as those not living in affordable housing. So there is a lot more to do, and we continue to work with that population. The second example I will talk about is Black women undergoing regular mammography screening. So we have a large navigation program, and it's successful in navigating women who have barriers, including insurance access transportation barriers, to successful breast cancer screening. So our advisory council said, why can you not take that program and expand it to colon cancer screening? Well, there are some barriers. The reason we are able to offer free screening is we have the breast and cervical cancer early detection program funded through the CDC. It provides us money. If we find someone, it will help for diagnostic tests and provides money for treatment. There is nothing like that for colon cancer, and we are not Delaware. So what do? The thing is that, and one of the things we started noticing is that all these women we were trying to navigate, some of them have insurance, they would go for their breast cancer screening, but not for their colon cancer screening. So we collaborated with internal medicine, with an internal medicine practice in MedStar Washington Hospital Center, and all patients are seen there. All of these women have undergone mammography screening, so there is no insurance access barrier. They're coming to a tertiary care center, our tertiary care center, so there is no reason, so it's not about awareness. They're all there. So what we decided was, over a 3-month period, we identified, among looking at the EHR, about 106 women, all African-American, above the age of 45, who were up to date on their annual mammography, but non-adherent to CRC screening. we know that the biggest barrier to not having colorectal cancer screening is not having a provider recommendation for colorectal cancer screening. Turns out all of them had an automatic referral to colonoscopies, screening colonoscopies. None of them had gone to that. So now this is a population where on paper, they don't have barriers. They're there. Provider gave them a colonoscopy referral. There's no colonoscopy done. So they're not up to date. So what we decided to do is through a navigation program, we decided the provider would contact them, ask them for their interest in taking part in the program. Our navigators, bilingual navigators, would contact them, and we would do this intervention. So we would navigate them. So we contacted about 45 women out of that 106. That's another barrier about not being able to reach people that we can talk when we are discussing. But out of those we contacted, just the fact that they were asked about it, you will see that about 7 of them went ahead and scheduled their colonoscopy. So it was, for some of them, it was just about a reminder that you need to get this. But about 34 women, they agreed to come to our office and talk to us, and this is what we did. We talked to them about this colorectal cancer screening. Which test would I prefer? A preference-based test that is free and live on the Office of Disease Prevention side for the NIH. And it asks you 7 simple questions about how do you feel about doing colon prep, going for a doctor's visit, do you have any transportation barriers, do you have someone to bring you back after your colonoscopy, and how worried are you about risk of complications from a colonoscopy, and then how frequently do you want to screen? Do you want to do fit kit screening every 1 to 2 years, or do you want to be one and done for 10 years? So based on their preference, the program actually tells them, based on what you told me, it seems like this is what you would prefer, a fit kit or a colonoscopy screening. And then our navigators talked to those women, and based on that, they decided whatever they would decide, we would do. We would either give them a fit kit, and if it's positive, we would navigate them to a diagnostic colonoscopy, or we would navigate them to a screening colonoscopy. So this is what happened. Remember, all of them had been given a referral, automatic referral by the physician for colonoscopy screening. About 40% preferred a fit kit. Out of the 40% who preferred a fit kit, the ones in blue are the ones who actually completed it. A large majority of them completed it. Of those who preferred colonoscopy, again, about 50%, more than 50%, about 60% of them actually went ahead and got their colonoscopy. A couple who are in orange have gotten their colonoscopy since. They were just a little bit late to scheduling. So this was a really simple intervention. Have someone, didn't really create a new tool, used an existing tool, just had a conversation, which is really hard when people go to their primary care provider because of the billing pressure and the time pressure. So we need to go a little bit beyond traditional medical care and start thinking about these support systems, because even though these are women who don't have barriers, they still have barriers. So based on the results of that study, we are now funded through a DC Department of Health program to do just this, a quality improvement program to increase colorectal cancer screening in primary care practices. The last one I'll talk about is another special populations that we don't seem to talk about when we talk about colon cancer screening. What about cancer survivors from other cancers? We know that there are about 7 million people living in the United States who are breast and prostate cancer survivors. Just the fact that they had this cancer means that they're at increased risk of a second primary, including colon cancer. They should be screened, but there are no programs focused on cancer patients. In fact, most of our messaging is screening is for people who have never had cancer. So what we did is we looked at prior research has mostly focused on differences between colon cancer screening between either survivors versus the general population or just breast cancer survivors. What we didn't know is what are the barriers to colorectal cancer screening within a survivorship population. For this, we collaborated with a MedStar practice in Southern Maryland. It's a large practice, 21 locations, 5 counties, about 300,000 patients that it sees. And we did an EMR-based retrospective cohort study. We identified breast and prostate cancer diagnosed prior to 2015 and greater than equal to 50 years of age who had no history of colorectal cancer colorectal cancer diagnosis. And we followed them up till the end of 2018. And we were trying to see how many of them were up to date with their colon cancer screening recommendations. So we had about 2,000 patients, more than about 1,100 or 1,000 breast cancer survivors, 891 prostate cancer survivors. So this was published this year. And this is what we looked at. Are there disparities by age, gender, race, ethnicity, residence? So about half of them were living in large metro areas, others in small metro or non-metro areas. And what about comorbidities? If we look at obesity, hypertension, diabetes, does that have anything to do with colon cancer screening? This is what we found. Overall, only 51% compared to the 73% I showed you earlier in the general population, only 51% of the breast and prostate cancer survivors are up to date on the colon cancer screening. And men were more likely to be up to date on theirs compared to women, which is a flip of what you usually see in the general population. In the general population, women have a higher up-to-date colorectal cancer screening than men, at least in DC. But this was completely flipped, and it was statistically significantly different. If you look by age, there was a much bigger difference in age in prostate cancer survivors. Again, we are surprised. The younger age group, less than 65, were more likely to be up to date. The older age group, who should be screened because their risk of colon cancer increases as they age, were not being screened. If you looked at up to date by residents, you would expect that people living in large metro areas would be more likely to get screened, but turns out that's not true. These community-based practices were doing a much better job of making sure the cancer survivors were getting screened compared to the large tertiary hospitals, where as soon as someone has a cancer diagnosis, we don't think about screening that much. And finally, when we looked at black and white differences, there did not seem to be a difference. Initially, we looked at it in unadjusted models. There was a difference, but as soon as we adjusted for residence and comorbidities, that went away. In fact, in odds ratios, black patients were more likely to be screened than white patients. So what about comorbidities? Obesity and diabetes did not seem to be associated with colon cancer screening after adjusting for other things. Hypertension was one of the strongest risk factors. People with hypertension, and African Americans have more physician visits with hypertension than Caucasians, were more likely to be screened. So what we wrote in the paper was that this is probably due to increased primary care visits and increased likelihood of getting a referral to colon cancer screening. However, we did not have data on the number of primary care visits, so we are still looking at this issue. So only hypertension was associated with colorectal cancer screening. Usually, comorbidities are not recognized to be strong mediators of colorectal cancer screening in the general population. But again, this is not the general population. It's a cancer survivorship population, and things are different here. So I think, again, when we talk about these disparities, and we are talking about survivors, I think we should leave some of the evidence that we have gotten from a non-survivorship population and reassess some of those in a survivorship population. So thank you very much. Thank you for your patience. And you can find us at the Office of Minority Health.
Thank you, Dr. Dash. Dr. Gifford, you could join us on the stage. We're going to open up now for question and answer session. So please feel free to ask questions. I'll start by kind of going back to the clinical trials question for a piece. And one thing I struggle with is, in designing clinical trials, we want to certainly obtain the most robust science out of the study, which often incorporates biopsies, potentially extra visits, but this can be a barrier to participation in underserved populations. And so I guess just any comments from the panel on clinical trial design and how we can, as investigators, better design clinical trials to be more inclusive.
I'll start by saying absolutely. This is something we're trying to tackle now. We have a clinical trials access committee that's working on this as a part of our diversity, equity, and inclusion efforts at the Farber. And one of the things that we push back on is it really necessary to have that biopsy? Is it really essential to the quality and the outcomes of the study to have the labs done at our site? Right? So can we modify some of the elements of the study design that are really more a convenience for the team, convenience for the research team, and really do not reflect the essential science that you want to gain from the study? So we learned a lot during COVID. I had a patient who was an older adult that was in a different state on a clinical trial. And immediately as COVID struck, was told he can't be on the clinical trial anymore, despite his advances, significant advances in survival. And we pushed back. As a primary care team, we said, why is that? And the research team pushed back as well. And the sponsor said, you know what, you're right, there's no reason for that. And this patient was able to remain on study for all of 2020, receiving his medications locally, having his labs done locally, having his scans done locally, and we still being the reviewers. So I think it taught us a lot. It taught the research team a lot. It's worthwhile advocating for these things before we plan them in trials, and really walking through the steps of participation in the study and asking yourself, is this something that I could do if I was working? Is this something I could do if I'm a care provider for someone who's younger or older? Is this something I could do if I'm feeling queasy or nauseous, right? Really walk through the practicalities of the study before we say that's essential to the study design. Oftentimes it's not.
So I'll just add something to that. Part of the question was also about biopsies and biospecimen and the complexities of that. A few years ago, we published a study on what are the barriers or what are the factors associated with biospecimen donation in an African American population. And the narrative is that because of historical injustices like the Tuskegee study and the other studies, people are unlikely, people don't trust them. Turns out none of them knew about the Tuskegee study. There was nothing historical about the mistrust. It was very much present. They were not told why there were biospecimens were being collected. They were not really told about the study. And in some cases, they're not even asked about it. So what they are responding to, I think in many cases, is how people behave with them now, not what people behaved with them from people of their race or ethnicity.
While we're on clinical research, you guys gave us a lot to think about. So first, thank you. The first one was, what is race a surrogate for? So we don't actually design trials stratifying for race, or almost never do we, but we retrospectively look at it as we think we're looking for some sort of surrogacy. I think we're looking for some sort of difference. In our GI cancer world, we will always shout out if a study was done in Asia versus Western, even though we don't really know if there's any difference in outcome between those. We say, well, we said it this morning, well, that was an Asian population, suggesting that the result might not translate to a Western population. And yet we don't know why that would be so. We just hypothesize it as a surrogate. And so I understand the need for representation, okay, which is different to me than being studied, right? I mean, are you represented? And then if we can't define surrogacy, should we in some way on the back end, maybe in phase 4 studies or the like, should we ask sponsors of studies to demonstrate that there either is or is not any racial difference in outcome, and try and study that specifically? So that's a big roundabout of this concept of surrogacy, putting it in table 1 when we don't really know what we're talking about, and how should we come around on that?
And I can start. This is on. I think the answer should be flipped back to the researcher or whoever's doing the answer, I think, is depending on who's doing the study. I mean, it's not trying to be a flip answer, but depending on who's doing the study, they're interpreting that race variable in very different ways, but usually it's not necessarily operationalized. So I think the answer to your question, unfortunately, is we don't know. And what I would say is that we need to more explicitly, since you're going to include, since you're going to include race as a variable, to very explicitly say, race in this case we're using as a proxy for whatever it is, and just to be explicit about it. And, so I think that would be, the way I would solve that problem.
A common question I receive from African-American patients is, in the data that you're quoting to me, what is the sample size for African-American patients? So does that data apply to me? And so whether, perhaps there is a biologic difference or in certain treatments, because the populations are often underrepresented, populations are often minimal in clinical trials. I think capturing that data can be important because maybe there are subtle differences there that we're missing.
I think I would add one more thing to that. I think race in some contexts can represent cultural practices. So I think of the PROMISE study by Irene Gabriel that is active right now. It's a multiple myeloma study. It's focused specifically on African-American patients, although enrolls all comers. And I think the brilliant part of that study was they adopted and adapted kind of what they thought would work based on what patients were saying, really to reflect some of the cultural practices in terms of how you have conversations about cancer and cancer diagnoses and risks in African-American or Black populations. And so the study was designed with that in mind, and they were very explicit, I think, to Dr. Griffith's point, to call out, this is why we're looking at this population, because of these factors that are really germane to the success of this trial.
Just one more thing. When we talk about race as a proxy for biology, we're at a point where we don't really need to do that. So this goes back to what you said. We kind of should come forward and say, this is why I expect a difference. If you think it's because of ancestry, well, measure ancestry. There are ancestry information markers. Go ahead and measure ancestry and figure out, well, is it due to ancestry? If it's due to biology, well, actually measure the biology of that. No one is saying that we need to look in a clinical trial for differences between Blacks and whites. If you need to do that, you need to be powered for it, right? What we are saying, I think, what I think we mean to say is that your clinical trial should reflect the population you're doing it. If there is no difference between, if there's no biological difference and everyone is white, well, then why don't we just take, like Dr. Marshall said, results from Japan or South Korea and just apply it to the United States? Why this double standard? So that would be, it's about representation. And it's because previously we've had situations where, for cardiovascular disease, a lot of trials, the feeling was that, well, it's okay to have only men in cardiovascular treatment trials because women are just men with pesky hormones, right? Right? So that's what, I didn't say it. I said it, but I didn't say it. So, but turns out they're not. And we don't know enough. About 40% of the African genome, we don't know. So we are not even there. We know there is diversity, there's variability, but we're not doing it more. So we need to do more.
But what I'm sort of getting at is how do then we change the system, the environment? We're not looking at what's happening in the body, but what's happening around.
Correct.
To answer these questions and
Right.
not just expect it to passively kind of come along
Right.
with the goodwill
Right.
of people. And that's, I think, if we're going to answer those questions, if we don't see a difference in a 200 patient study, that doesn't mean it's not there.
Right.
And so how do we then structure, and the government has put some money down to help try and support this, right? So from a clinical research perspective, we should wrap our heads around how we do trials in a way that, at least in the end result, answer those questions or try to answer those questions. Yes or no?
But I think to answer your question, some of it can be as simple as sort of a culture change of what sort of was described before. And I think it was Dr. McCleary's study that she was talking about. When it was required that they did X for all patients, then that changed, and you started to see an improvement, not just in the Black population, but you saw it in all populations. So if you make it sort of a common practice where it's not, where you have to say, here's why I'm doing this, or here's why I'm not. And that just becomes part of the culture of how you do science at your institution. It fundamentally changes how you do everything else. So I think it can be that basic and that simple as, why are we including this? Why are we not? How are we thinking about it? And I think that, again, that's the fundamental part of science, is that we have these a priori hypotheses that we're then testing, as opposed to doing post hoc stuff where we're just trying to figure out, oh, we found something, now we're trying to make sense of it. So the more that we can sort of a priori bring these things out, the better. I think the other quick thing I would say to your other question about should the phase 4 trials, I think to something Dash said, yes, we should use, I'm gonna get in trouble for this, but I'll say it anyway. Yes, we might decide race, but I think there are other factors that you could also make the case, given the context and given the issue, that you should also consider. And so race may not always be the factor that needs to be the primary thing that you would stratify on. You have to have, again, some logical reason and some explicit scientific reason why you're looking at things by a particular socially defined or health-related, variable that has some implications.
And one last point to that is, we can ask those questions in a scientifically rigorous way, like we are doing with, so one of our studies right now at Lombardi is focusing on the disparities that we see between Black and white women. Is it due to obesity-related DNA repair capacity differences? So you can actually go ahead and ask those questions, and someone will fund you if the science is good.
I mean, I think this discussion then feeds to me, in my way of thinking, of the trust question. Is that if there is dedicated strategy and priority, that helps trust, I think. And what I run the risk of getting in trouble with this comment is that, yeah, for sure. Listen to Lucille's meeting right now. I think a lot of our systems, including our healthcare system, is built for the haves. And it reflects accrual at Dana-Farber, it reflects accrual at Lombardi, okay? And so clinical research is for self-enrollment in clinical trials, but it's also for other. There is an element of that. And why should somebody that's not my institution, why would I volunteer to help your cause, right? Whereas, maybe a white person sees that as their cause, right? And so I don't know if what I've said has any resonance at all, but as we seek to bridge the trust piece of this, ownership of the healthcare system and contribution, their role, everyone's role in that healthcare system matters. So am I way off on that, or is that something we need to, as a guy who's in charge of the clinical operation at Lombardi, how do we help bridge that trust and make them feel like that's their home too?
I would say a part of trust in healthcare has to do with honesty and about expectations. And if we are not clear when we're consenting patients, whether it's a clinical trial or standard therapy, whether it's supportive care, end-of-life care, whatever it is, if we're not honest as to what our expectations are, then that trust is always going to be undermined, no matter who is in front of you. I've had patients, Black, white, high socioeconomic status, low socioeconomic status, folks who are legally and illegally employed, who have all said that that was the most important thing to them, is that they understood clearly that there was an outcome that was expected, that we would be honest about it, that we would communicate, and not me to them, but both ways, right? And so we would go back to this conversation several times throughout care. In the story that I shared with you, the diagnosis was changed, but the story is very true. And that delay, unfortunately, of a year is very true. And I was actually shocked that there was still enough trust, and the trust, and this was an interview that I shared with you based on my research coordinator asking Mary, so I was not present when these questions were asked. And she said to the interviewer that it was really because we were honest and we were upfront and we set the expectations, and we also said, this may not work. This may not work despite your effort. And we were also very clear, don't do this for us. Don't do this because your friend is in the room. Do this for you. If you think this is going to be beneficial for you, if you see some hope in it. And I think that's what allows her not only to go through that clinical trial, but also to continue beyond progression on treatment.
just want to add to that because I really believe that when you're running the clinical operations, we have to address implicit bias. We have to address explicit bias, and we have to address cultural competency. I think without those topics being at the forefront, we will stay behind. No matter what we do or what we talk about, we have a lot of implicit bias that rages and implicit bias that rages. And we often lack the cultural competency to address the different communities, the different cultures, the different foreign-born, native. We just don't do it. And we don't do it well. So I think that's something we have to do, which means we often have to diversify our portfolio in terms of the people that serve with the staff and the leadership so that we can actually promote this type of inclusion. We're not inclusive enough because of the lack of those types of things.
Comments?
Yeah, I agree 100%. When we look into the, over the last year and a half, we've been more open in talking about kind of structural and institutional racism. And I think that in order to, one aspect in terms of moving this field forward is to diversify our clinics, diversify our staff, because I think that patients, when they come into the door, they look for that, and they're not always, but often can be inherent trust in someone who looks like you do. And so as we continue to advance the cancer field, we need to have more leaders who are minorities who can sit at the table, be in the boardrooms, design the studies to push the field forward.
The other, I think there was something also implicit in, I think, your question about sort of how do you do this differently, and for folks who may not feel like it's their center or the study really fits them. I think part of it is dispelling the myth that science done on one population may not apply to another. And usually we're used to science that's done on white populations we're used to translating that to populations that are not white. What we're not used to doing is thinking about populations who are not white and then translating it to white population. Yet there's a lot of purchase in being able to do that and being able to show that those relationships do actually matter. So I think, just being clear about that and to help dispel that myth for people, whether it's the patients or the providers or the researchers, I think is part of what we need to start to do.
You joked about left-handed. We don't, that's not in table 1.
The brilliance, yes.
But, we ignored in colorectal cancer, everybody in the room knows, we ignored right-sided colon cancers were not as good as left, even in terms of prognosis. So we ignored that because we couldn't explain it.
Right.
And we still can't explain it, but now it matters therapeutically. So we've now embraced it. So maybe we should start having table 1 with left-handed and right-handed. And then the ambidextrous people that, kind of split the difference.
There's an online question for Dr. McCleary regarding Dana-Farber patients. Do they have to consent to allow their genetic data to be used in research in order to access lower cost next generation sequencing?
Yeah, absolutely. So, I tell patients, quite frankly, there's certain things that we do that are a part of your care. You consent to general care. The general pathology review is a part of your care. You consent to that. For the additional genomic testing, if it's in a research study, you absolutely have to consent to that, and it has to be informed consent. There is an opportunity for patients to participate in biobanking studies and tubert samples and organoid studies, and all of that they do have to consent to. So it is consent that is given before procedure is done, and the consent can also be withdrawn, and there's a procedure in place to remove consent and all the samples that could be used in that after the fact as well.
I was going to take us to a different place if I could. I got one more sort of set of questions, and it's around screening. I mean, my understanding, what I was taught, is that screening for the general population should be inexpensive, non-invasive, with as good a sensitivity and specificity as you can get. And yet our national advocacy groups and culture is that the best test is an invasive, expensive test that requires 2 days off from work. So you've automatically created a standard which is unachievable for a significant portion of the population, which may be overrepresented by African Americans. Okay, So, your study about, if you got a choice between the poll questions that sorted you into, you'd probably be a better fit person than a colonoscopy person. We haven't been beating that message enough. And so, and there are a lot of forces in play that are colonoscopy dominant. So it's back to de-escalation to improve overall uptake. So anybody want to go at that and how we do that?
I was also going to ask Dr. Marshall's public sex sciences, which is the COVID DNA test, but also that we're adding to the pool of another 20 million people between the ages of 45 and 49. So I mean, I think that this is an issue that a lot of the GI community with their guidelines and how they're making some of their top tier recommendations. But of course, I'll let you go, Dr. Marshall.
No, that's a great point. And when I was a graduate student at Emory, and I was an intern with the American Cancer Society, I was fortunate to sit in the guidelines committee meeting for colorectal cancer screening, and it was interesting. I presented them the science. They probably talked 5 minutes about the science, and then they started fighting. So it was all about it was all about the revenue, and at that point it was between the radiologist and the gastroenterologist, right? So, and then the stool DNA came the next 2 years later, and then another faction came in, but. The way they have gone, and Dr. Marshall is right, we're the only country, even Europe, which is considered developed, I think, doesn't consider colonoscopy as a screening test. It considers it as a diagnostic test. So we consider colonoscopy as a screening test. We put a dollar amount to it that if we do these many colonoscopies, it will cost this much, we'll find one cancer. Is it acceptable? And turns out, yes, it is acceptable. Not for public transport, but for this, yes, it is acceptable. But the move that has happened, though, is that colonoscopy is no longer a screening test. It's a screening plus prevention test now. So that kind of changes it theoretically from a scientific point of view. You get screened. It's not just that we are detecting cancer early. We can find these adenomas, which are precancerous lesions, and you won't even get cancer. So some other countries are going that way, but again, you're absolutely right. I spent 2 years of my life looking at risks of complications to colonoscopy, and they're non-trivial in rural populations.
Yeah, I would agree, but I think the answer is almost somewhat implicit in the question, is that we need to re-educate the folks who are making the decisions about simplicity, the distinction between a screening test and a diagnostic. And even we found this a lot with data, is that a lot of the data, merges screening and diagnostic data. And so we can't actually disentangle when somebody is getting screened for something and when it's actually, there was symptomatic and it was really something more than just sort of broad scale screening. So I think going back and clarifying and making sure people understand the difference, and then using the influence of folks in positions that will be listened to actually make those kind of changes and push that kind of agenda would be helpful.
Sort of my last comment on this and also it's kind of a bioethics question. In lung cancer, payers, health insurance payers, will sometimes have programs where they'll pay like $10 a month, send them a check or $10 to not smoke. And so because the money works out, right? That's a good idea. And I always think about the same thing as, why aren't payers in this game? And that if you've done your screening, whether it's a fit test or whatever, your monthly or annual costs will fall, or we'll send you $100 back, right? So, and incentivize that, because in the end, that helps the overall pool, the insurance pool. And I don't see a bioethical problem with that. You've joined a club to pay for your health care. The club incentivizes you to be more healthy, right? So do you think that's something that would resonate in underserved populations?
in a way, they do it now. I mean, there are insurance companies, for example, Blue Cross Blue Shield would do that. They will ask you a bunch of questions. If you've done this, if you've gotten primary care at least once, you are taking care of this, you're having your blood pressure mentioned, they will reduce your premium. So, and then with what we're also doing, so for colonoscopy screening, what happened legislatively, they removed the copay, even though with Medicare, what happens is that there is no copay unless they find a polyp, in which case it becomes diagnostic and you have to pay. So which causes a problem, of course. But in any case, there are some incentives they give. The problem is, and this is what we are doing right now, AmeriHealth is the largest Medicaid provider in DC. In DC, on paper, very few people are uninsured, except they don't know they have insurance and they don't participate in any of the things. So AmeriHealth is talking to us to talk to those patients and navigate them into care. So there is a benefit for AmeriHealth in there. And then that's where we find other barriers. Here are people who supposedly have social support. AmeriHealth will provide transportation. They don't have people to call them. We call them, turns out the phone is switched off because they can't afford the phone bill. So you get into that other thing where, what Dr. Griffith and others have talked about, unless we fix those other social determinants, sometimes a simple solution becomes not so simple anymore.
I think the other go ahead.
No, go ahead.
No, I mean, I think, the other part of your question is, I think one answer to your question is to simply ask the population what would actually be useful. I think that's a very simple thing that we don't tend to sort of go to that makes a lot of obvious sense. It does sound like the barrier to this payer issue or that kind of incentive is not on the patient or the receiver side, it's the one who's doing it. And I think part of their logic is, you're doing a test that you're looking at either that is once every 2 years or once every 10 years. And so there's not the same benefit to something that is a behavior that you're actually doing on a regular basis. So if it was mapping it to something that's more of, say, eating behavior or something that is more of a sort of direct you're having to make the change more on a regular basis, then I can see them being more likely to want to do something that would actually change that, incentivize a change that would be something on that regular basis.
Left-handed people do fit testing in odd years. Right-handed people do fit testing in even years.
Well, just how frequently they would do it. So like if you gave them, if they chose the fit test that sort of Dash was saying, for example, if I could see them say, okay, let's incentivize them every time they're supposed to get a fit test. Versus, with lung cancer, it's like, okay, you're trying to stop them from smoking every day. So then you're trying to get them to do something on a more regular basis. So, yeah.
I have time for one more question, if there are any other questions out there.
Let's give our panel a very nice round of applause. It's an amazing group. Thank you all very much.